Good day. This week in CDA, we shall be discussing the assessment and diagnosis of fluids and electrolytes imbalance. These are my disclosures. There are three types of homeostatic balance that we see in our system. Number one is water and electrolyte balance, which we shall be discussing this week. Acid-base balance, which is a separate topic and will be discussed in CDB. The balance is maintained by a collective action of urinary, respiratory, digestive, integumentary, endocrine, nervous, cardiovascular, and lymphatic systems. So the total body water is a percentage of the lean body weight, and the value would decrease depending on the age. 80% of the total body weight is composed of water in younger patients, and 60% of lean body weight is in adults. That is why babies and infants would get dehydrated easily as compared to adults. Total body weight is lower in females than in males. It's around 50% in females, and 60% in males. And it also is lower with increasing obesity and loss of muscle mass. There are two compartments separated by the cell membrane. This is the extracellular fluid compartment and the intracellular fluid compartment. So what are the body fluid compartments? So 40% of our body weight is composed of solids, whereas 60% is composed of fluids. So the total body fluids, two-thirds are found intracellularly, while one-third is found extracellularly, wherein 80% of that one-third is found in the interstitium or in between the cells, whereas 20% is found inside the blood vessels with the plasma. So the ECF is greater in infants and young children compared with older patients. That is why babies get dehydrated faster compared to adults. In normal adults, the ECF constitutes approximately 33% of the total body weight and is determined by the absolute amounts of sodium and water that is present. The interstitial fluid, which is the fluid or the water between the cells, which comprises around 80% of the extracellular fluid, and around 20% is found in the blood or intravascular, which is in plasma. And then we also have what we call the transcellular fluid. This is composed of lymph, the CSF, synovial fluid, the aqueous humor in the eye, the vitreous body, endolymph, perilymph, which we see in the middle ear, the contents of the body cavity such as the pleura, the pericardium, and the peritoneum. The intracellular fluid volume in adults constitutes around 67% of the total body weight. Potassium salts are the main intracellular solutes. An ICF volume is usually larger than extracellular fluid volume because there are more potassium salts in the cells than sodium salts in the extracellular compartment. So there are two barriers that separates the ICF, interstitial fluid, and plasma. So this is the plasma membrane, which separates the ICF from the surrounding interstitial fluid, and the blood vessel wall, which divides the interstitial fluid from that of the plasma. So let's not talk about body water spacing. So first spacing is the normal distribution of fluids in the extra and intracellular fluid compartment, whereas second spacing is the excess accumulation of fluid in the interstitial space, also known as edema. Third spacing is the fluid that accumulates in areas that normally have no fluid or minimal amount of fluid, like what we see in ascites or accumulation of fluid in the peritoneum or edema associated with burns, and this would cause relative reduction in volume or relative hypovolemia. So 1 liter of water weighs around 2.2 pounds. A sudden weight gain or weight loss is the best assessor of the status of our fluids. The patient had to have their fluid status monitored. That is why if you see some patient charts, the input and their output, or their intake as well as the output, are monitored. So body gains water by, of course, ingestion of fluids and food that are moist, and this would constitute at around 2.3 liters per day, as well as from metabolic synthesis of water, which constitute around 200 ml per day. And we lose water through the kidneys around 1.5 liters per day, evaporation from the skin, which constitutes 600 ml per day, and from the lungs around 300 ml per day, and from the stool around 100 ml per day. But this would depend also, the losses in the stool as well as in the skin would depend on the weather as well as the character of the stool. So if you look at this diagram, so 10% from metabolism of water, around 250 ml, from the moist food that we eat, around 30%, and for beverages, around 1,500 ml. And then these are the sources of losses per day. So from the sweat, around 100 ml, that's 4%. From the sweat, it's 8%. And then insensible losses via the skin and the lungs is around 28%. And the majority of our output or the loss of water is through the urine. So regulation of water intake, the thirst mechanism is seen or found in the hypothalamus. The regulation of water output, very active in this function, would be the DCT and the collecting ducts of the nephrons. In the event of a decrease in water loss, the ADH and aldosterone would be working hard, whereas in the increasing water loss, it's the atrial natriuretic peptide that would be working or regulating the water output. So the fluid imbalances could either be dehydration, hypovolemia, hypervolemia, and water intoxication. So dehydration is the loss of body fluids with increased concentration of solutes in the blood and a rise in serum sodium levels. The fluid which would shift out of the cells into the blood to restore the balance. And then in the end result would be shrinkage of the cell from the loss of fluid, and the cells or the tissues can no longer function properly. So how do they manifest? They may manifest with any of this: irritability, confusion, dizziness, weakness, thirst, decreased urine output because you have lost too much water. The cooling effect of water is also lost, so some patients would manifest with fever. Of course, the more telling symptoms or manifestation will be dryness of the skin, the mucosa. There will be sunken eyes, as well as poor turgor of the skin, and some may even have or manifest with increase in heart rate. Let's talk about hypovolemia, wherein there is an isotonic fluid loss from the extracellular compartment. This could progress to hypovolemia. So what is caused, or what causes hypovolemia? It may be caused by excessive fluid loss, like what we see in hemorrhage, or a decrease in fluid intake, and third space fluid shifting. It may present with mental status deterioration, thirst, increase in heart rate, delayed capillary refill. Some may even have orthostatic hypotension, wherein they get dizzy when they stand up. The urine output would reduce to around 30 ml per hour. And some of us or some of these patients may even present with cool, pale extremities and, of course, weight loss. On the other hand, hypervolemia is the excess or accumulation of excess fluid in the extracellular compartment as a result of either fluid or sodium retention, excessive intake, or renal failure, wherein the kidneys is unable to do its function. This occurs mainly as a compensatory mechanism. This occurs when compensatory mechanism fail to do its action of restoring fluid balance. This may lead to congestive heart failure and pulmonary edema. So patients may present with tachypnea or increase in respiratory rate, difficulty of breathing or dyspnea, crackles, rapid bounding pulses, hypertension, an S3 gallop on auscultation, probably an increase in central venous pressure, which is measured by the Swan-Ganz catheter. There will also be a jugular vein distension or neck vein engorgement. There would be weight gain as well as edema. How about water intoxication? There is hypotonic extracellular fluid shift into the cells to attempt to restore balance. And of course, the end result, there will be cellular swelling. So where do we see water intoxication? Number one would be in the instances of SIADH, or of syndrome of inappropriate ADH secretion. This happens in certain instances, like for example in brain trauma, wherein a part of the pituitary is affected. It also happens is as a paraneoplastic syndrome in certain forms of small cell cancers of the lungs. It may also be seen in rapid infusion of hypotonic solution, excessive tap water, which you see from nasogastric irrigation or infusion of enema, or psychogenic polydipsia, which also be seen in certain endocrine disorders like diabetes insipidus. So there are three forces that seems to balance the fluid in the different compartments. Number one is hydrostatic pressure. So this is the pressure of blood fluid against the capillary wall. If the hydrostatic pressure in the interstitial fluid and solute, this is the one that forces the fluid out of the blood. And other one is osmotic pressure. This is the water movement from area of higher to lower concentration through a membrane that is permeable to water but not to solute. And there is no energy needed because that is another process we're in. Another is plasma colloid oncotic pressure, which is wherein the central figure is the pulling force of albumin in the intravascular space. So this would oppose hydrostatic pressure to maintain equilibrium of fluid leaving and returning into the vascular compartment. Hypertension or hypoproteinemia, which it could cause hydrostatic pressure to surpass the colloidal oncotic or osmotic pressure, then edema would result. So let us talk about electrolytes this time. So electrolytes move between the intra and extracellular compartment via the concentration and electric gradient. So diffusion on the let's define diffusion is the movement from higher to lower concentration. Facilitated diffusion wherein there is a specific carrier molecule that is needed to accelerate diffusion, which is different from active transport because molecules would move from an area of low to high concentration with the use of external energy, usually in the form of ATP. So this is different from facilitated diffusion wherein you have a specific carrier. So electrolyte intake may be or could come from the food or the drink or could be produced by as a byproduct of metabolism. And the output of electrolytes is achieved or is uh, is achieved through sweating. You may also lose electrolytes in the stool as well as in the urine. So how do we regulate or what regulates the electrolyte output? Of course, number one would be aldosterone, which is secreted by the adrenal cortex. It exerts its effort on the kidney to regulate the excretion of sodium and potassium. And potassium ions are excreted when sodium ions are conserved. So this is an exchange, if you still remember your lectures in physiology. So regulation of electrolyte output. For example, calcium concentration is regulated by a parathyroid hormone which increases the concentration of calcium as well as phosphates in the extracellular compartment, and the other hormone which opposes the effect of parathyroid hormone is calcitonin, which basically does the opposite of that of the parathyroid hormone. So extracellularly, the most abundant cation is sodium. Intracellularly, it's potassium. Extracellularly, the most abundant anion is chloride, whereas intracellularly, the most abundant intracellular ions are proteins and phosphates. So this is just a diagram to show you the free movement of ions across the extra and intracellular compartment. So sodium is, as we say, is 90% of all the extracellular cations. So this is usually combined or it combines with chloride and bicarbonate to help regulate the acid-base balance. So that is why we often monitor sodium in cases of head injuries because it may cause cerebral edema. So there are several types of hyponatremia or decrease in serum sodium. One would be dilutional as a result of water gain. So accumulation of fluid would result to dilutional hyponatremia. Then we also have what we call depletional hyponatremia, wherein there is insufficient intake of sodium. Then we also have hypovolemic hyponatremia, wherein sodium loss is in excess of water loss. It may be renal as a result of a diuretic use, or a non-renal cause like what we see in patients who are vomiting. Hypervolemic hyponatremia, wherein water gain is more than sodium gain, and then edema will occur. And then we also have isovolemic hyponatremia, wherein there is normal sodium but there is too much fluid, or there is fluid retention. So what causes hyponatremia? It may be lost through the gastrointestinal tract, like from uh, diarrhea. It may be as a result of excessive sweating, like if you exercise outdoors during the summer months. The use of certain medications like diuretics. What you also see this in an endocrine disorder wherein there is a deficit in aldosterone, like what we see in Addison's disease. It could also be lost from burns as well as drainage of wounds, infusion of hypotonic intravenous fluid such as D5 water and 0.45 sodium chloride. Hyponatremia may also accompany congestive heart failure, SIADH, or syndrome of inappropriate diuretic hormone secretion, renal failure, as well as water intoxication. So what are the signs and symptoms of hyponatremia? How do we recognize hyponatremia? Primarily, the most of the manifestations of hyponatremia are neurological in nature. Like most patients would present with headache, or some would present with mental status changes. For example, they might be lethargic, confused, some may be stuporous, and some may end up in coma, and some may even present with seizures. Others would present other manifestations would be nausea, cramps in the abdomen, twitching of the muscle, tremors, weakness, of course, plus signs and symptoms of volume disturbances. Let's talk about the opposite, which is hypernatremia. Dehydration, fever, head stroke, and sweating. Watery diarrhea and diabetes insipidus may all cause hypernatremia, as well as water deprivation and sodium gain from excessive intake, as well as what you see in Cushing syndrome or hyperaldosteronism. So what do we see, or how do we recognize hypernatremia? The earliest sign would be there will be puffiness of the face of the patient. You have to think of the mnemonic SALT: S for flushing of the skin, A for agitation, L for low-grade fever, and T for thirst. So they may also present with weakness as well as neurologic manifestations such as changes in sensorium, as well as in certain or in severe instances, they may also have intracranial bleeding. Now let's talk about chloride or hypochloremia or decrease in chloride. So what are the causes? It may be due to chronic kidney disease, congestive heart failure, prolonged diarrhea and vomiting. You also see this in chronic lung diseases, metabolic alkalosis, as well as intake or abuse of certain medications such as laxatives, diuretics, corticosteroids, and certain chemotherapeutic agents. So how do we recognize hypochloremia or decrease in serum chloride? Patients may present with agitation, irritability, slow and shallow respirations, as well as signs of dehydration. Let's now go to the opposite of hypochloremia, which is hyperchloremia. Again, it may be due to dehydration, increased intake with sodium drugs that contain sodium, as well as in cases of hyperaldosteronism. So how do we recognize symptoms of hyperchloremia? Patients may present with hyperventilation, arrhythmia, tachycardia. Patients may be lethargic, some may be weak, others would be edematous, and most of the symptoms are related to metabolic acidosis. Next of the electrolytes or ions would be potassium. The monitoring of potassium is important especially if you're dealing with heart and muscular diseases. So, what are the causes of hypokalemia? It may be spurious, wherein there is no real loss of potassium, but it may be just due to artifactual causes like an increase in WBC count or insulin injection, wherein the insulin would facilitate the entry of potassium into the cells. Also, in cases of diarrhea, the use of laxatives and diuretics, also in people who are fasting excessively, intake of licorice, it's some type of a candy, as well as renal losses. So, what are the, or how do we recognize the signs and symptoms of hypokalemia? So, think of the mnemonic suction: S for skeletal muscle weakness, U for wave or changes in the ECG, C for constipation or ileus, T toxicity of digitalis and glycosides, I for irregular weak pulse, O for orthostatic hypotension, and M numbness or some paresthesias or the pins and needles sensation. Let's talk about hyperkalemia. One is also a spurious cause of hyperkalemia. It's not exactly an increase in uh, serum potassium, but rather more of an artifactual cause like hemolysis and delayed separation of the cells from the serum may increase the potassium spuriously, as well as prolonged tourniquet application during blood extraction. You may also see this in overdose of digitalis, deficiency in aldosterone, renal failure, and a lot of drugs, mostly those that would mostly some of the drugs that would preserve or conserve potassium, like potassium sparing diuretics. So the signs and symptoms in hyperkalemia, or how do we recognize them? Again, we see some irregular pulse, or could be abnormality in the ECG, wherein you may see peak tall T waves as well as prolongation of the PR interval. Patients may also present with irritability and anxiety, abdominal cramping, and diarrhea. Patients may also experience lower extremity weakness and paresthesia or tingling sensation, or what we call the pins and needles sensation. Next of the electrolytes would be calcium. Ionized calcium is approximately half of the entire or the total serum calcium. And to get an accurate ionized calcium results, the blood must be collected with dried heparin and should be analyzed within the window period of 30 minutes, and it has a very narrow reference range. So what causes a decrease in serum calcium? For one would be in chronic renal failure, alcoholism, the use of loop diuretics, magnesium or vitamin D deficiency, hypoalbuminemia, um, hyperphosphatemia, as well as losses from the gastrointestinal tract. Hypocalcemia may also accompany hypoparathyroidism. Ionized calcium would also decrease in alkalosis, as well as transfusion of large amounts of citrated blood, as well as of donation of blood by apheresis. So how do you recognize symptoms of hypocalcemia? First, number one would be patients may experience or complain of circumoral paresthesia or the tingling sensation around the mouth. Um, Reflexes are said to be hyperactive. Some patients may present with tetany and laryngospasm. Uh, they may also present with Vostex and Trousseau sign. So what is Vostex sign? If you tap on the root of the facial nerve, there would be involuntary twitching of the facial muscles. Trousseau sign would be the cramps or the spasm of the fingers of the fingers if you try to occlude or try to block and compress rather the upper extremity, maybe from a tourniquet or a blood pressure cuff. Patients may also present with diarrhea, anxiety, seizures, and fractures as a result of the brittling of the bones as a result of a decrease in calcium. So there will also be prolongation of the QT and the ST segments in the ECG. So what causes, on the other hand, an increase in serum calcium? Of course, increased intake, intestinal absorption like intake of vitamin A and D, overdose of vitamin A and D, release from the bone, hyperparathyroidism, as well as in paraneoplastic syndrome like which accompanies certain forms of cancers in the lungs like squamous cell carcinoma. Yung SIADH, as I've mentioned, is seen in small cell carcinoma of the lungs, whereas hypercalcemia sa paraneoplastic syndrome accompanies certain forms of lung cancer like squamous cell carcinoma. So how do we recognize hypercalcemia? There is usually a decreased neuromuscular excitability. It would manifest as a GI motility problem and neurological irritability. On the ECG, it may present with shortened ST segment and widened T wave. So, for you to remember them, stones, bones, groans, and psychic overtones. So this is the best way to remember signs and symptoms of hypercalcemia. Then lastly, we have magnesium. This is needed for around 300 biochemical reactions in the body. It helps maintain normal nerve and muscle function and supports a healthy immune system and helps the bone to remain strong. It also aids in the production of energy and protein as well as regulation of glucose levels. So what causes a decrease in serum magnesium? Well, alcohol use, burns, chronic diarrhea, and you have all of these listings. So how do you recognize hypomagnesemia? Number one, patient may present with nystagmus, seizures, fatigue, muscle spasms or cramps, muscle weakness, numbness, and on ECG, it's just almost similar to hyperkalemia. They may present with a tall T wave and ST segment depression, which can be mistaken as myocardial infarction. On the other hand, what causes an increase in serum magnesium? Renal failure, those who are undergoing dialysis, excessive intake, lithium therapy, excessive intake, especially those who are taking antacids containing magnesium, lithium therapy, lithium is an antipsychotic medication, hypothyroidism, Addison's disease, as well as your familial hypocalciuric hypercalcemia and the milk alkali syndrome, which accompanies hypercalcemia in a setting of metabolic alkalosis. You also see this in depression. Again, how do we recognize hypermagnesemia? They may present with decreased reflexes, muscle weakness, some may present with confusion, decrease in breathing rate, hypotension, bradycardia. On ECG, it may present with prolonged PR or widening of the QRS complex. So these are the components of a complete metabolic panel. So you have calcium, chloride, potassium, sodium, carbon dioxide, glucose, BUN, creatinine, TPAG or your total protein albumin globulin ratio, total bilirubin, alkaline phosphatase, and the transaminases. So these are my references. Thank you.